Welcome to the Epidemiology and Prevention of Vaccine-Preventable Diseases webinar series. I'm Andrew Kroger. I'm a medical officer in the Immunization Services Division of the National Center for Immunization and Respiratory Diseases, or NCIRD, at the CDC, and I'll be the moderator for today's session. To participate in today's program, all you will need is an internet connection. Here are our learning objectives. At the conclusion of this session, the participant will be able to describe the different forms of immunity, describe the different types of vaccines. For each vaccine-preventable disease, identify those for whom routine immunization is recommended. For each vaccine-preventable disease, describe characteristics of the vaccine used to prevent the disease. Describe an emerging immunization issue. Locate resources relevant to current immunization practice. And implement disease detection and prevention healthcare services, for example, smoking cessation, weight reduction, diabetes screening, blood pressure screening, immunization services to prevent health problems and maintain health. Today is July 20th, 2016, and on the agenda is the Epidemiology and Prevention of Vaccine-Preventable Diseases Pink Book, specifically the vaccine topic DTaP Tdap, which draws from the chapters on diphtheria, tetanus, and pertussis. This will be presented by Dr. Candace Robinson, a medical officer in the Communication and Education Branch, or CEB, of the Immunization Services Division, ISD, of the National Center for Immunization and Respiratory Diseases, or NCIRD. Continuing education, or CE credit, is available only through the CDC ATSDR Training and Continuing Education Online System at www.2a.cdc.gov/TCE online. If you are watching this version live, CE credit for the session will expire on August 22nd, 2016. If you're watching the Enduring Archive version, CE credit for the session expires on June 1st, 2018. When obtaining CE, you'll be required to provide a verification code. Watch and listen for the verification code during the course. Verification codes will not be given outside of this presentation. CDC, our planners, and our presenters wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Presentations will not include any discussion of the unlabeled use of a product or a product under investigational use, with the exception of Dr. Robinson's discussion of the use of DTaP DT vaccine in a manner recommended by the Advisory Committee on Immunization Practices but not approved by the Food and Drug Administration. CDC does not accept any commercial support. A list of resources for DTaP and Tdap will be available and the web page is www.cdc.gov/vaccines/pinkbook/pb7.asp. If you have a question during this presentation and related to this presentation, please type your question into the QA pod. I'll collect these questions during the presentation, and then we will address them during the question and answer period, which will follow Dr. Robinson's presentation. And so now I will turn the microphone over to Dr. Robinson. You may.
Thank you, Dr. Kroger. Good day. Within the Pink Book, content regarding diphtheria can be found starting on page 107, pertussis content starting on page 261, and tetanus content starting on page 341. Diphtheria is a toxin-mediated disease. The disease is transmitted mainly person to person via the respiratory tract and rarely through the skin or fomites. It can infect almost any mucous membrane and is classified based on the site of infection. Most commonly, it affects the nasopharynx and causes an exudate, and within 2 to 5 days may form an adherent membrane on the pharynx and tonsils, which can lead to respiratory obstruction. As they grow, the bacteria produce a toxin that is absorbed into the bloodstream. The absorbed toxin causes most of the complications of diphtheria, such as myocarditis or inflammation of the heart and neuritis, which leads to abnormal nerve conduction. Diphtheria results in death in 5 to 10% of cases. This picture depicts the tough adherent membrane in the back of the throat that can include the airway. It can cause serious bleeding with efforts to remove it. This chart shows the number of diphtheria cases reported annually in the U.S. from 1980 through 2011. Fewer than 5 cases of diphtheria have been reported each year in the U.S. since 1980. Since 2000, a total of about 5 cases have been reported. The majority of reported cases are among persons 25 years and older. There is no current geographic concentration of cases observed in the U.S. However, the greatest risk of infection is during travel outside the U.S., where diphtheria is more prevalent. Tetanus is an acute, often fatal disease caused by a toxin produced by the bacterium Clostridium tetani. The bacteria and its spores are found everywhere in the world that has dirt, animal feces, and may persist for months to years. We will never eradicate tetanus. One of the toxins, tetanospasmin, blocks the impulses in certain nerves, which leads to unopposed muscle contraction and spasm. It is one of the most potent toxins known to man. The most common form is generalized tetanus. The disease usually presents with a descending pattern. The first sign is trismus, or lockjaw, followed by stiffness of the neck, difficulty swallowing, and rigidity of abdominal muscles. The complications of tetanus include spasms of the respiratory muscles, which can lead to respiratory arrest. Muscle spasms can be so severe they break bones. If the person doesn't die as a direct result of the tetanus, they may die from the complications that come along with long hospitalization and recovery. This chart shows the number of reported tetanus cases from 1990 through 2012. There's been an overall decline in cases since 1980. During 2001 through 2008, the last years for which data has been compiled, a total of 233 tetanus cases were reported, an average of 29 cases per year. Among the 197 cases with known outcomes, the case fatality rate was 13%. Age of onset was reported for all 233 cases. The median age was 49 years, with a range of 5 to 94 years. 49% of cases were among persons 50 years of age or older. Among the reported tetanus cases, 72% reported an acute wound before disease onset, such as a puncture or contaminated wound. 13% reported a chronic wound before disease onset, such as a diabetic ulcer or dental abscess. This is a picture of a child with generalized tetanus. The exotoxins are causing his back to curve, giving his body this contorted appearance. We will spend a little more time on pertussis. Pertussis is a highly contagious respiratory infection caused by the bacterium Bordetella pertussis. Disease onset is insidious with nonspecific cough and minimal fever. The incubation period is 5 to 10 days. There are 3 stages. The catarrhal stage is characterized by runny nose, sneezing, low-grade fever, and mild cough, like the common cold. This is the stage where maximum communicability occurs. During the paroxysmal stage, the diagnosis is usually suspected because of the characteristic bursts of rapid coughs, because the person is unable to get rid of thick mucus from the trachea and bronchi. This is followed by the characteristic whoop. Patients can turn blue and children can look very ill. The most common complications reported is secondary bacterial pneumonia. Other complications include seizures. Approximately 16% require hospitalization. Finally, during the convalescent stage, cough is less paroxysmal and gradually disappears. This phase can last weeks to months. This graph illustrates the number of pertussis cases reported to the CDC from 1922 to 2014. Following the introduction of pertussis vaccines in the 1940s, when case counts frequently exceeded 100,000 cases per year, reports declined dramatically to fewer than 2,000 by 1965. During the 1980s, pertussis reports began increasing gradually, and by 2014, more than 32,000 cases were reported nationwide. Why? Immunity from acellular pertussis vaccines wanes after a dose, within 5 years after the DTaP series and less time after one dose of Tdap. This graph shows reported pertussis incidence per 100,000 persons by age group in the United States from 1990 to 2014. Infants aged less than 1 year, who are at greatest risk for serious disease and death, continue to have the highest reported rate of pertussis. School-aged children, 7 to 10 years, continue to contribute a significant proportion of the reported pertussis cases. In 2008 through 2014, a total of 118 deaths from pertussis were reported to CDC. Of these 118 pertussis-related deaths, 95, or 81%, were infants younger than 3 months of age. In 2014, there were over 32,000 cases of pertussis reported in the U.S. Over 50% of the cases in 2014 were in persons 11 years and older. Pertussis infection in this age group may be asymptomatic or present as classic pertussis. Disease in adolescents and adults is often milder than disease in infants and children, but even persons with mild disease may transmit the infection. Older persons and household contacts, such as parents, siblings, grandparents, and babysitters, are often a source of infection for infants and children. However, pertussis in adolescents and adults is not without consequence. Illness can have a prolonged cough that can persist for 3 months or longer. Post-tussive vomiting may occur after a severe paroxysm of cough. Adolescents and adults may also develop complications of pertussis, such as difficulty sleeping, urinary incontinence, pneumonia, and rib fracture. Adolescents and adults often have multiple medical visits and may undergo extensive medical evaluation for the persistent cough before pertussis is considered as the diagnosis, and they may miss school or work. In summary, diphtheria, tetanus, and pertussis are diseases that can occur throughout the lifetime, and vaccination needs to occur throughout the lifetime to be protected. Now, let's shift our focus to the vaccines. DTaP vaccine, it's big D, big T, little a, little p, is the pediatric formulation. DTaP is approved for children 6 weeks through 6 years of age, that is up to the 7th birthday. DTaP should not be administered to anyone 7 years or older. DTaP contains the same amount of diphtheria and tetanus toxoid as pediatric DT vaccine. As of April 2012, there are 2 pediatric DTaP products available in the United States, DAP and Infanrix. These vaccines have been studied in either blinded cohort studies or in case control studies. They have an estimated 3-dose vaccine efficacy of 80 to 85% against typical pertussis disease. Although the vaccines contain different formulations, there is no clear evidence that one is significantly more effective than the others. As a result, neither ACIP nor AAP has stated a preference for one of these vaccines. In addition, there are 4 combination vaccines that contain DTaP. In December 2002, the U.S. Food and Drug Administration approved Pediarix, a combination vaccine that contains DTaP, inactivated polio, and hepatitis B vaccines. It is produced by GlaxoSmithKline. The DTaP component is Infanrix, and the hepatitis B component is Infanrix B, which were previously licensed in the United States. Pediarix is approved for the first 3 doses of the DTaP and IPV series, which are usually given at about 2, 4, and 6 months of age. It is not approved for the 4th or 5th doses of the DTaP series. The minimum age for the first dose of Pediarix is 6 weeks. It cannot be used for the birth dose of the hepatitis B series. The vaccine is not approved for use in children 7 years of age or older. Pediarix can be given to infants who receive a birth dose of Hep B vaccine. These infants would receive a total of 4 doses of Hep B vaccine. An important fact to remember about Pediarix, and any other combination vaccine for that matter, is that the minimum intervals between doses are dictated by the single antigen with the longest minimum interval. Therefore, Pediarix minimum intervals are determined by the hepatitis B component. As with hepatitis B vaccine, the minimum interval between the first 2 doses of Pediarix is 4 weeks. The 3rd dose must be administered at least 8 weeks after the 2nd dose and should follow the 1st dose by at least 16 weeks. Hep B will be covered in a future module. The second combination vaccine that contains DTaP is Pentacell, produced by Sanofi Pasteur. The vaccine contains DTaP, inactivated polio, and Hib vaccine. Pentacell is FDA approved for doses 1 through 4 of the DTaP series among children 6 weeks through 4 years of age, that is up to the 5th birthday. Pentacell should not be used for the 5th dose of the DTaP series or for children 5 years or older. Pentacell must be reconstituted prior to administration. Lyophilized Acthib is reconstituted with a liquid DTaP IPV solution. You should only use the manufacturer-supplied vaccine diluent. The last 2 combination vaccines are a combination of DTaP and inactivated polio vaccine. Kinrix, manufactured by GlaxoSmithKline, and Quadracil, manufactured by Sanofi Pasteur. Each are approved for use in children 4 through 6 years of age, and only as the 5th dose of the DTaP series. They should not be used for doses 1 through 4 or for children younger than 4 years of age. This table is a summary of all of the DTaP containing vaccines. Be sure to administer the correct DTaP vaccine based on the age of the child and the DTaP dose you are administering. There are a few data on the interchangeability of pediatric DTaP vaccines. ACIP recommends that whenever feasible, the same DTaP vaccine should be used for all doses of the series. But if the brand of vaccine used for the earlier doses is not known or not available, then any brand may be used to complete the series. Now we will discuss the primary DTaP schedule. DTaP vaccine is recommended for all infants and children. A primary series in infancy is 4 doses, beginning at about 2 months of age. The first 3 doses are usually separated by 2 months. The 4th dose should follow the 3rd dose by at least 6 months and should be given at 15 to 18 months of age. If an accelerated schedule is needed, the first dose can be given at 6 weeks of age, with the 2nd and 3rd doses given at 4-week intervals. DTaP can and should be given simultaneously with all other childhood vaccines the child needs at these visits, with a separate syringe and at a separate site, of course. We received many questions about the appropriate age for the 4th dose of DTaP. The 4th dose of all brands in licensed and recommended by ACIP to be given at 15 to 18 months of age. But ACIP also states that the fourth dose may be given earlier than 15 months in certain circumstances. Specifically, the fourth dose may be given earlier than 15 months of age if the child is at least 12 months of age and it's been at least 6 months since the third dose of pertussis vaccine, and in your opinion, the child is unlikely to return for an additional visit at 15 to 18 months of age. The age and timing of the dose at school entry can also be confusing. A fifth dose of DTaP at 4 through 6 years of age is recommended when the fourth dose is given before age 4 years. This final dose in the DTaP series should be administered no earlier than the 4th birthday and at least 6 months after the previous dose. You will encounter children who have received all 5 doses of DTaP prior to the 4th birthday. A booster dose of pertussis vaccine prior to school entry is important to maintain pertussis immunity throughout the school years. ACIP recommends that children who have received the 5th dose prior to 4 years of age receive an additional dose of DTaP after age 4 and at least 6 months after the previous dose. Diphtheria and tetanus toxoid, or DT vaccine, is approved for use in children 6 weeks through 6 years of age. It is given as a 3 or 4 dose series depending upon the age the child received the first dose. Pediatric DT is used for children with valid contraindications to pertussis vaccines. If the child was younger than 12 months old when the first dose of DT was administered, the child should receive a total of 4 primary doses. If the child was 12 months of age or older when the first dose was administered, 3 doses complete the primary series. 4th or 5th dose at school entry is not needed if pertussis vaccine is not being administered. The next slides will discuss first contraindications and then precautions to administering DTaP. These are the true contraindications to receiving the DTaP vaccine: severe allergic reaction following prior dose and encephalopathy not due to another cause within 7 days of vaccination. Of note is that encephalopathy, though reported previously with the use of the whole cell vaccine, has not been associated with acellular vaccines. As with all other vaccines, moderate or severe acute illness is a precaution for DTaP vaccination, and vaccination should be deferred until the acute condition improves. If any of the next 4 events occur following pertussis vaccination, then additional doses of pertussis generally should not be given. Temperature to 105 within 48 hours of vaccination with no other identifiable cause. Collapse or shock-like state within 48 hours. Persistent inconsolable crying lasting more than 3 hours, or convulsions with or without fever occurring within 3 days of vaccination. All of these precautionary conditions have been reported following both whole cell and acellular pertussis vaccines. While they're scary, they don't result in permanent injury, nor do they predict future reactions. DTaP hasn't been associated with any permanent brain injury. If one of these reactions occurred following a dose of any type of pertussis vaccine, you wouldn't normally give additional doses of pertussis. This series would be completed with pediatric DT. But remember that precautions require your judgment. You need to determine if the benefit of pertussis vaccine outweighs the risk of recurrence of the adverse reaction. If so, you may choose to give the vaccine. For example, one of your patients is a normal 6-month-old who had a fever of 105 the day after his second DTaP. Now, there's a large community-wide pertussis outbreak going on. You may choose to vaccinate this child because the risk from disease exceeds the risk from vaccination. As with all injected vaccines, DTaP may cause the following adverse reactions. Local reactions have been reported in 20 to 40% of children after the first 3 doses. Fevers in 3 to 5% of children are usually self-limited and can be managed with ibuprofen or acetaminophen. More severe adverse reactions are not common. Local and systemic reactions like fever are more common after the 4th and 5th doses. The cause and frequency of these unusual reactions is not known, but they appear to be self-limited and resolve without sequelae. There have been reports of swelling of an entire limb following the 4th or 5th dose of DTaP vaccine. Parents should be informed of the increase in local reactions that has been reported following the 4th and 5th doses of DTaP. ACIP recommends that a history of extensive limb swelling after the 4th dose should not be considered a contraindication to receipt of the 5th dose at school entry. Now we're going to discuss Tdap and TD vaccines. Tdap vaccine, big T, little d, little a, little p, is the acellular pertussis vaccine for adolescents and adults. The big T and little d should help remind you that these are vaccines for older persons like adult TD. Both Tdap vaccines are approved by the Food and Drug Administration for a single booster dose for persons who have completed the recommended childhood DT/DTaP vaccination series. Tdap contains less diphtheria toxoid and acellular pertussis antigen than DTaP. Boostrix is approved for persons 10 years of age and older. Adacil is approved for persons 10 through 64 years of age. A single dose of Tdap is routinely recommended for adolescents 11 through 18 years of age, adults 19 through 64 years of age, and adults 65 years of age and older who have or anticipate having close contact with an infant less than 12 months of age. On the Tdap row in the vaccination schedule, you will notice that Tdap may be used in children 7 through 10 years of age. The current FDA-approved minimum age for Tdap vaccine is 10 years for Boostrix and Adacil. The maximum approved age for all DTaP vaccines is 6 years. No pertussis-containing vaccine is approved by the FDA for children 7 through 9 years of age. ACIP recognized that some children 7 through 9 years of age need pertussis vaccine, in particular those who have not received a complete series of DTaP before their 7th birthday. ACIP recommends that children 7 through 10 years of age who are not fully vaccinated against pertussis and who do not have a contraindication to pertussis vaccine should receive a single dose of Tdap to provide protection against pertussis. Either brand of Tdap may be used. Tdap is recommended in this age group because of its reduced antigen content compared with DTaP, resulting in a lower risk for local adverse reactions. After review of available data on the safety and immunogenicity of pertussis vaccine among children 7 through 10 years of age, ACIP voted to recommend off-label use of Tdap in this age group. Not fully vaccinated against pertussis is defined as having received fewer than 4 doses of DTaP or having received 4 doses of DTaP but the last dose was prior to age 4 years. If additional doses of tetanus and diphtheria toxoid containing vaccine are needed, then children 7 through 10 years of age should be vaccinated according to the catch-up schedule. Now to discuss Tdap and Td use in adults. Administer Tdap to those 19 years of age and older who have not received Tdap or with unknown vaccination status. When feasible, Boostrix should be used for adults 65 years of age and older because it is approved by the Food and Drug Administration for persons of this age. However, either Tdap vaccine administered to persons 65 years of age and older provides protection. Td is routinely recommended for use every 10 years following a dose of Tdap vaccine. Td is also approved for primary series doses. All adolescents and adults should have documentation of having received a primary series of at least 3 doses of tetanus and diphtheria toxoids during their lifetime. A person without such documentation should receive a series of 3 doses of tetanus and diphtheria containing vaccines. One of these doses, preferably the first, should be Tdap. The remaining 2 doses should be adult formulation Td. Here is the preferred schedule. After the first Tdap dose, the second dose of Td should be administered at least 4 weeks after dose 1. The third dose, Td, should be administered at least 6 months after dose 2. Booster Td doses should be administered every 10 years thereafter. Now let's discuss Tdap in pregnant women. Tdap is recommended in pregnancy to provide the infant with protection from pertussis. ACIP recommends that providers of prenatal care implement a Tdap immunization program for all pregnant women. Healthcare personnel should administer a dose of Tdap during each pregnancy, irrespective of the patient's prior history of receiving Tdap. Because antibody levels wane substantially during the first year after vaccination, ACIP concluded a single dose of Tdap at one pregnancy would be insufficient to provide protection for subsequent pregnancies. To maximize the maternal antibody response and passive antibody transfer to the infant, optimal timing for Tdap administration is between 27 and 36 weeks gestation, although Tdap may be given at any time during pregnancy. For women not previously vaccinated with Tdap, if Tdap is not administered during pregnancy, Tdap should be administered immediately postpartum. No study has assessed the safety of repeated doses of Tdap in pregnant women. Data is reassuring on 2 doses of Tdap. Additionally, data and experience with tetanus toxoid vaccine suggests no excess risk of adverse events. Using data on the number of pregnancies the average woman will have, it is estimated that only approximately 5% of women would receive 4 or more doses of Tdap in their lifetime. CDC provides ongoing monitoring and assessment of the safety of Tdap use during pregnancy. Now for another special population, healthcare personnel. Healthcare personnel should receive a single dose of Tdap as soon as feasible if they have not previously received Tdap, and regardless of the time since their most recent TD vaccination. Priority should be given to vaccination of healthcare personnel who will have direct contact with infants 12 months of age and younger. Tdap is contraindicated for persons with a history of a severe allergic reaction to a vaccine component or following a prior dose of vaccine. Tdap is also contraindicated for persons with a history of encephalopathy, not due to another identifiable cause occurring within 7 days after administration of a pertussis-containing vaccine. Precautions to Tdap include a history of Guillain-Barré syndrome within 6 weeks after a previous dose of tetanus toxoid-containing vaccine. If a patient has a progressive neurologic disorder, such as uncontrolled epilepsy or progressive encephalopathy, Tdap vaccination should be deferred until the condition has stabilized. Persons with a history of a severe local reaction or TUS reaction following a prior dose of tetanus or diphtheria toxoid-containing vaccines should generally not receive Tdap or TD vaccination until at least 10 years have elapsed after the last TD-containing vaccine. Moderate or severe acute illness is a precaution to vaccination. Persons for whom vaccination is deferred because of moderate or severe acute illness should be vaccinated when their condition improves. It is worth mentioning that some conditions that are precautions to the use of pediatric DTaP are not precautions to the use of Tdap. ACIP believes that these conditions are unique to young children and are not expected to be an issue among adolescents or adults. The most common adverse reaction following both brands of Tdap vaccine is local reactions such as pain, redness, or swelling at the injection site. Temperature of 100.4 or higher was reported by 1.4% of Tdap recipients and 1.1% of TD recipients. Tdap recipients also reported a variety of non-specific systemic events such as headache, fatigue, and gastrointestinal symptoms. Local reactions, fever, and non-specific systemic symptoms occurred at approximately the same rate in recipients of Tdap as compared to a group that received TD without a cellular pertussis vaccine. No serious adverse events have been attributed to Tdap. Here are some additional resources for diphtheria, tetanus, and pertussis, as well as DTaP and Tdap vaccine recommendations. There is also a link to the CDC's pertussis and pregnancy website, which provides resources for discussing pertussis vaccine with pregnant patients, as well as posters seen on the introductory pertussis and pregnancy side. And with that, I will turn the session back over to Dr. Kroger.
Thank you very much, Dr. Robinson. Now on the screen, you will continuing education credit information, most importantly, the verification code for today's course. Please make note of this verification code as it will not be given outside of this presentation. Today's verification code is 16-DTaP, and this verification code applies to both the live program and the enduring program. I'll repeat the verification code. It is 16-DTaP. There also, as you'll see, is a resource pod on your screen where you can click on files to obtain instructions for CE. So now I will review some of the questions we've received during the program. Please continue sending these to the QA pod. I will remind listeners that if you have questions related to the recent ACIP vote on cholera vaccine, meningococcal vaccine, and LAIV vaccine, we are not going to address these today on this program. Please send them to the NIP Info email address that I will give you at the end of this program. And so, Dr. Robinson, the first question we received is one we've heard before. It has to do with the fact that if we know that pertussis immunity wanes quickly after a dose of Tdap, why are we not recommending more frequent booster vaccinations?
Yes, thank you, Andrew. Yes, this is a question we have received before. Currently, Tdap is only approved by the Food and Drug Administration for a single dose. Therefore, any such recommendation at this time would be considered off-label use. The ACIP has reviewed this issue in June of 2014 and October of 2014. Currently, the data suggests that revaccination would have a limited effect on the burden of pertussis disease in the United States, as many adults have not received their first dose of Tdap vaccine. I will note that the highest morbidity and mortality of pertussis is in infants, and there is a strategy in place for this age group. The ACIP strongly supports focusing efforts on preventing pertussis in infants through the existing recommendations to vaccinate pregnant women during each pregnancy. So with these issues, CDC and ACIP concluded that data does not favor a general recommendation for a second Tdap and therefore does not favor a universal recommendation. We are aware that the manufacturers of Tdap vaccines are collecting data on revaccination, and we will discuss this issue potentially again in the future if the manufacturers have additional data and if the vaccine is approved for additional uses.
Okay, great. Thank you. Yes, we receive a lot of questions about that. Why not a booster dose? And I'm sure we'll receive that question again in the future. Here's another question that was written in. It has to do with the difference between the two vaccines. So which vaccine should be given to a 7-year-old that still needs the diphtheria, tetanus, pertussis protection? Should they receive TD vaccine or do they receive Tdap?
So if the 7-year-old needs protection for tetanus, diphtheria, and pertussis, then they should receive the Tdap vaccine. And as mentioned in the presentation, while it is not FDA approved, the ACIP recommends this vaccine for use in this age group, specifically because it is recognized that some may be undervaccinated and need protection.
Okay, thank you. Here's one we received. Why is Pentacell not recommended for the last DTaP dose?
It's not FDA approved for that indication. Thus, it's not recommended because that use would be outside of the FDA approval.
Okay. We did receive a question about clarification of the rule about using minimum intervals with combination vaccines being based on the longest minimum interval. Can you kind of talk about that a little bit more? They just wanted some clarification on that.
Certainly. So I believe that example, we discussed that when I was discussing the Pediarix vaccine. So for instance, Pediarix contains 3 vaccines. You have DTaP, Hep B, and IPV, or polio. When using each of those vaccines individually, each vaccine has a different minimum interval for administration. Your minimum intervals for use of polio are different from your minimum intervals for use of hepatitis B. When you have a combination vaccine like this, you want to look at the minimum intervals for all of the vaccines contained within that combination vaccine. So you want to look at the minimum intervals for DTaP, Hep B, and IPV in the case of Pediarix. Among those, you want to follow the minimum intervals for that vaccine component that has the longest minimum interval. So in this case, between DTaP, Hep B, and polio, Hep B has the longest minimum intervals. So you want to follow that one. So you just want to make sure whenever you're using a combination vaccine, you evaluate the minimum intervals for each vaccine contained within that combination and follow that minimum interval.
Sounds good. Thank you very much. You mentioned when a child younger than 7 years of age receives a dose of Tdap inadvertently, let's say it's for the 4th or 5th dose, they receive it. Can they still receive another dose of Tdap after the 7th birthday?
Hi, yes. So if a child inadvertently received a dose of Tdap, let's say for the 5th dose at school entry, that child can still receive Tdap when they come for their adolescent visit between 11 and 12 years of age.
Got it. Thank you. Here is a question. We did receive a question. Is there a pertussis only vaccine available?
So currently there is not a pertussis only vaccine available. There is just combination vaccine of the Tdap. but there's no pertussis-only vaccine available.
Okay, great. We did receive a question about, actually it was kind of specific to diphtheria, but it would apply to diphtheria and tetanus as well. With the incidence of these diseases, diphtheria and tetanus being so low, why should we continue to vaccinate against these diseases?
True that these diseases are rare in the US, and this is likely due, at least in part, to the success of vaccination. However, these diseases have not been eradicated, and therefore, without vaccination, there is a possibility of infection. The bacterium that causes tetanus is ubiquitous and present in the soil, and while diphtheria is more prevalent outside of the United States, there could be an unreported case here in the US because physicians don't regularly consider this diagnosis, and laboratories will not test for the organism unless specifically told to do so. So again, while incidence of these two diseases are low here in the US, we still require lifetime protection against these organisms.
Okay, thank you very much. Question about healthcare providers. Are there any special recommendations for Tdap vaccines for healthcare providers, whether they work with infants or?
So it is recommended that all healthcare providers have a history of receiving a Tdap vaccine. So you should, make sure they've all received that vaccine. If you have a healthcare provider that has not received Tdap vaccine, then it is recommended that that healthcare provider receive the vaccine as soon as possible, regardless of the interval since their last TD vaccine. Priority in general should be given to healthcare providers who will be interacting with infants and children less than 1 year of age, but it is recommended that all healthcare providers have a Tdap vaccine.
Okay, thank you. A question, you mentioned the contraindications and precautions, and there was just a question about acute illness. Why is acute illness a precaution for this vaccine?
With all of our vaccines, moderate to severe illness is a precaution and for vaccination. Reasons for that vary. I know there is some consideration that if a person is severely ill, they may not fully respond to the vaccine as they would if they were healthy. So it's a contraindication, or it's a precaution rather, I should say. It's a precaution for all vaccines, the moderate to severe acute illness. However, once that illness has passed and the person is deemed healthy enough to receive the vaccine, they should be vaccinated.
Okay, thank you. We had a question about use of Tdap in pregnancy. You mentioned a range of weeks by which you vaccinate in pregnancy. Can Tdap be given at any time in pregnancy or only during that time period?
So between 27 to 36 weeks is the recommended optimal timing for vaccination. However, vaccination can be provided at any time during pregnancy. So if you have a pregnant woman and they received that vaccine at another time in pregnancy, that's acceptable. But the optimal time range is 27 to 36 weeks.
Got it. Okay. Some more questions are coming in. Please continue to send your questions. You'd mentioned that you talked about the 6-month interval between the 3rd and 4th dose of DTaP. However, the immunization schedule notes that the 4th dose does not need to be repeated if it was given 4 months after the 3rd dose. So which is the correct interval?
Yeah, so the recommended interval between the 3rd and 4th DTaP doses is 6 months. If you have a child in your office who received their 3rd dose but has not yet received their 4th dose, you should wait until 6 months after the 3rd dose to administer the 4th dose. However, if on retrospective patient chart review, you find that a child received the 4th dose only 4 months after the 3rd dose, that child would not need to repeat the 4th dose. The 4-month interval rule is only for retrospective review of immunization records, and it is not for proactive immunization scheduling.
Got it. Thank you. Here's a question. If you have a patient who is older than 7 years of age, let's say, and they've received 2 doses of DTaP in the past, what are the recommendations for this adolescent today?
So if you have a 7-year-old who received 2 doses of DTaP in the past, then since they've only had 2 doses, they would fall under that not fully immunized category that I had. And as a reminder, people who are not fully immunized are children 7 through 10 years of age who have had fewer than 4 doses of DTaP or 4 doses of DTaP and the last dose was before 4 years of age. So in that situation, that 7-year-old would be recommended to receive Tdap at that visit.
Got it. Thank you. Here's a clarification question just about Tdap use in pregnancy. So if someone is pregnant in back-to-back years and they did receive Tdap with the prior pregnancy, they should receive another dose of Tdap. It's only 1 year later.
Yes, that is correct. So even if they were pregnant the year before, it is recommended that they receive a new dose of Tdap with each subsequent pregnancy.
How about if an adult that is older than 65 years of age and they received a dose of Tdap prior to age 65, should they get another dose of Tdap after the 65th birthday, or like even if they're going to be around a newborn? Or
so if they've already had a dose of Tdap, then they do not need another dose after 65. However, if they're 65 years of age or older and they have no documentation of having received that Tdap and they're going to be around an infant, then you want to make sure they're vaccinated.
How about the spouses of pregnant women? Are the pregnant women get it in every pregnancy? Do their spouses get Tdap with every pregnancy as well?
So the spouses would get Tdap if they have not received Tdap in the past. So if it's the first pregnancy and the dad has never received Tdap, you want to provide dad with Tdap. However, for subsequent pregnancies, the dad would not be revaccinated. It's the mother that would be revaccinated with each pregnancy. So as long as the dad has the vaccination history of having received a Tdap, he does not need another one with each subsequent pregnancy.
Okay, thank you. So here is a question about adults and tetanus vaccine for wound management. If adults have what's known as kind of like a dirty wound, they step on a rusty nail or a nail, or whether it's rusty or not, they have a wound, and their last dose was of tetanus-containing vaccine was 5 years ago. Are they recommended for another dose?
So there are specific recommendations for use of tetanus-containing vaccines for wound management, and if you see the ACIP recommendations website, you will find them there. But essentially, yes, if there's a dirty wound or they've, there's concern for a dirty wound, then yes, they would receive a vaccine, a dose of Tdap vaccine, even if the last dose was only 5 years ago.
Okay. Here's a question. Can DTaP IPV be given to a child 4 through 6 years of age who is behind on vaccination, and the dose of DTaP will be the 4th dose?
So the vaccine is FDA approved for DTaP for the 5th dose and not the 4th dose. So it would be recommended in that case to use a product that is FDA approved for that dose, and not the combination vaccine if it is not the 5th dose.
Yeah, but in most cases we'll count it if it happens. But
certainly,
we don't want
in
you
most
to
cases,
use,
if you did administer that combination vaccine, even though it's not FDA approved, you don't have to repeat the dose. So if it is administered, you don't have to repeat it. However, if you're proactively planning on which vaccine to use, it would be recommended for you to use a vaccine approved for the dosage,
Okay,
for the dose.
great, thank you. Question: if let's say an 8-year-old receives Tdap vaccine, can providers give another dose of Tdap vaccine later? For instance, if they're going to college, or should they just receive TD?
So if an 8-year-old received a dose of Tdap vaccine for, let's say they were catching up, they were not fully immunized and you needed a dose to catch up, you can administer that dose at 8, and then when they turn 11 through 12, they can receive the Tdap again for that adolescent dose.
Okay. Let's see, when we do one more question. Again, kind of on a common theme. So if Tdap was administered, let's say 4 years ago, and they have a dirty wound now, would they get a dose of Tdap now, or does the TD, does the Tdap dose, can it be used as prophylaxis for wounds? Is Tdap a substitute for wound prophylaxis?
Yeah, so both TD and Tdap have the same amount of tetanus toxoid within the vaccine. So if your facility only has Tdap and you have a patient with a dirty wound, you can absolutely vaccinate with Tdap instead of TD in that instance. We would not want you to miss the opportunity to vaccinate, specifically in a dirty wound situation, if you only have Tdap. Same amount of tetanus toxoid in each vaccine, it can be used if that's what you have.
Wonderful. Okay, thank you very much. Well, that's all the time we have for questions. So now I'm going to provide some continuing education credit information. Please go to the webpage www.2a.cdc.gov/TCE online to obtain credit. Today's live CE event course number is WC2645-072016. To repeat, WC2645-072016. That is today's date and differentiates this presentation from others in the series. CE credit for the live course will expire on August 22nd, 2016. You can search for the Enduring Archive course number, which is different. That lasts until June 1st, 2018, and that course number is WD2645-072016. You're also going to need the verification code, which is 16-DTaP Tdap. 16-DTaP. This verification code applies to both the live program and the Enduring program. Let me repeat that verification code, 16-DTaP. For help with the online system, available from 8 a.m. to 4 p.m. Eastern Time, please dial 1-800-41-TRAIN. This corresponds to the number 1-800-418-7246, or you can email ce@cdc.gov. If you have any additional questions that you didn't ask on today's program, you may email us at nipinfo@cdc.gov, and we'll try to respond to those as quickly as possible. We also will post answers to questions we didn't get to today at www.cdc.gov/vaccines/ed/PB7.ASP. That's the same URL that has our list of resources for this program. You can also call immunization questions to us at 1-800-CDC-INFO or 1-800-232-4636. That's from 8 a.m. to 8 p.m. Eastern Time, Monday through Friday. Additional resources you can use include the Pink Book, and the website for the Pink Book is www.cdc.gov/vaccines/pubs/pinkbook/index.html. It is available online, or you can purchase a hard copy at the link for the Public Health Foundation Learning Resource Center. Our CDC vaccine homepage is www.cdc.gov/vaccines/default.htm. Our resource guide for healthcare personnel, which is entitled CDC Immunization Resources for You and Your Patients, is listed at www.cdc.gov/vaccines/ed/IMZ-resources.pdf. Follow us on Twitter for immunization news, information, and resources for private and public healthcare personnel. That's at CDCIZLearn on Twitter. So that concludes our program. I want to thank Dr. Candace Robinson for the presentation today, covering the topic in great detail and for answering your questions. Thank you very much and have a great day from Atlanta. Goodbye.